So, continuing on our discussion about the anatomy of the human eye, we go on, or rather move on, to discuss the first, that is the outermost layer of the eyeball, in a great lot detail. So, as you can already see from the heading, that is the cornea and the sclera. So, these are the two structures of the eye that we will be discussing in a lot more detail than we did in the previous video. So if you don't remember the basic anatomy, I would obviously suggest that you watch the last video. But just to give you a quick recap, see, basically, if this was the eye, then this white portion over here, this was the sclera. And then in front of that rounded structure, the sclera becomes transparent and it becomes the cornea. So the cornea is a transparent structure. Why is it transparent? Because it has to allow light rays to travel through it. Otherwise, vision will not be possible, right? So we saw sclera, we saw cornea, which was transparent, and we saw that the junction between the cornea and sclera, that is a sclerocorneal junction, has been given a special name known as limbus. What limbus is specifically and why has it been given a special name, what exactly is its function, we'll see in this video itself. So let's start with the proper discussion of sclera and cornea, starting with cornea. So cornea is the transparent layer of the outermost covering of the eye. Outermost layer of the eye is also known as the fibrous layer. It does not have a fancy name as such. Overall, the outermost layer does not have a fancy name. The middle layer overall is known as uvea. The innermost layer is known as retina. But the outermost layer overall is just known as the fibrous layer. It does not have a specific name. Okay. So now let's talk about sclera, or rather cornea rather. Yeah, let's start with cornea. So cornea, obviously, as I have already said, it is transparent. Why is it transparent? I've already mentioned that as well, to allow light to pass through it. Okay. Now, is that all that cornea does? Is it transparent only so that light can travel through it? That is all it does. It does not add or subtract anything else from the way the light moves. No. It has been found out that cornea actually has some refractive power. In fact, not some. It has a lot of refractive power. Approximately plus 43 diopters. Diopters, if you do not know, is the unit for power. Optical power. So just to give you some idea as to how much plus 43 diopters is, remember we had talked about the crystalline lens in the previous video. I had said that the lens is the major structure in the eye which is used for refraction, which is used to converge the parallel light rays or light rays as a whole on the retina so that vision can form. Cornea also has a similar function. Except if the lens has a power of approximately plus 16 diopters, cornea has a power of plus 43 diopters, which means the cornea is the major structure which contributes to the refractory power of our eyes. That is how important this transparent layer in the outermost covering of the eye is. So knowing what cornea is, knowing about its different functions is very, very important, right? So I had mentioned something about the cornea being transparent and thus being avascular in the last video. Why is the cornea avascular? Obviously because it is transparent. To maintain transparency, a structure cannot be vascular, because if blood vessels are running through it, obviously what will happen? Blood vessels means blood, means fluid, right? And that would mean what? No more transparency, haziness. Haziness would develop. So obviously that is why the cornea is avascular. So if the cornea is avascular, but it is a living tissue, then it needs nutrients. It needs, it has its own metabolism, as we will see later, right now in this video. So how are those functions carried out? Well, I have already mentioned this in the previous video as well. For this reason, we have a special substance in our eyes known as the aqueous humor, right? Which is lodged within the anterior segment in between the lens and the cornea. Okay, we have all talked about this. Now, the cornea is avascular, so no blood. What about nerves? Does the cornea have nerves? That is, can the cornea feel in a way? Can it have sensations? Can it feel sensations? To elicit this, we try out something very, very simple and yet very interesting. It is known as the corneal blink reflex. What does this mean? We take a cotton wisp. What is a cotton wisp? Nothing. Just take a cotton and roll it in the form of a straight, fine, stick-like structure. Okay? A wisp. Then what we do is we touch the surface. Touch the corneal surface with that of a patient. In majority of us who have an intact corneal blink reflex, we will blink. If for some reason the cornea is anesthetized, that is, the cornea cannot feel, there are no sensations in the cornea, then the patient will not blink. What does this mean? This means that the cornea does have a nerve supply. Okay? This means the cornea has a nerve supply, right? So what exactly is the nerve supply for the cornea? Very, very interesting. It is TON. Remember, the cornea is where? In the eyes. The eyes are where? In the face, right? So anything, I would say, from the neck onwards will be supplied by what? The cranial nerves. So basically the cornea, for the cornea to have a nerve supply, obviously which nerve will supply it? Some cranial nerve will supply it. Now we know all the cranial nerves. Which cranial nerve can supply the cornea? Well, this is where memorization comes into play. And this is where the mnemonic TON comes into play. T stands for the cranial nerve. That is trigeminal nerve. Trigeminal nerve. Trigeminal nerve, if you don't know, is the fifth cranial nerve. Trigeminal nerve gives off the ophthalmic branch. Ophthalmic branch. The ophthalmic branch of the trigeminal nerve gives off the nasociliary nerve. So this trigeminal nerve to ophthalmic nerve to nasociliary nerve, this is the nerve supply of the cornea. Okay, so in short, it is the nasociliary nerve which supplies the cornea, but where is the nasociliary nerve coming from? It is from the ophthalmic branch of the trigeminal nerve. Done? Done. Now, trigeminal ophthalmic nerve, it has actually it has three branches. Like, this is extra information. We'll see to this later as well in the general anatomy sections. Ophthalmic nerve also has, this is nasociliary, it also has frontal and lacrimal. But it is the nasociliary nerve which we are interested in this video, because that is the one which supplies cornea. So this is how we deal with the corneal blink reflex, and this is how we test for it, and this is how we elicit that cornea indeed has a nerve supply. Now, if for some reason the patient is not eliciting a blink reflex, even after I'm touching his or her cornea with a cotton wisp, what can be the reason for that? In other words, what I'm asking is, what are the reasons for corneal anesthesia? Anesthesia, obviously, you know what anesthesia is. So basically, there is no sensations in the cornea. What are the reasons for that? Obviously, when I'm talking about corneal anesthesia, obviously, I haven't mechanically done anything to induce that corneal anesthesia. Obviously, if I apply some local anesthetic agent on the cornea, then obviously it will become anesthetized. That is not what we are talking about here. We are talking about some pathologies or some other stuff, basically, which lead to corneal anesthesia. The most important reason for corneal anesthesia is something that we'll talk about later as a pathology known as herpes keratitis. Okay, herpes keratitis. Herpes keratitis is the leading cause for corneal anesthesia, and in fact one of the hallmark features of herpes keratitis is corneal anesthesia. Okay, done. What are the reasons? Well, diabetes can be a reason. Leprosy can be a reason. We talked about herpes keratitis, another kind of keratitis which is acanthamoeba. Acanthamoeba keratitis. This can again be a reason. See, what does keratitis mean? Remember, in view of ophthalmology, anything starting with kera means cornea. Let me just make it very, very, very clear in this section itself that anything dealing with kera means cornea. Okay, keratosis, keratitis, anything, kera means cornea. So kera means cornea, and keratitis means what? Inflammation. So inflammation of the cornea. We'll talk about keratitis in a great lot detail in a different video when we'll talk about the corneal pathology of corneal ulcer, which is one of the most important pathologies in the eye. Corneal ulcer. There we'll talk about all these different types of keratitis. Herpes keratitis, acanthamoeba keratitis, viral keratitis, bacterial keratitis, all of these we'll talk about there. For now, just remember that these are the reasons for corneal anesthesia. What else? Well, contact lens. What about that? Yes, contact lens can also lead to corneal anesthesia. After contact lens, what else can cause corneal anesthesia? Topical timolol, long-term use. What is timolol? We'll talk about this later. Timolol is actually a beta blocker, which we apply in our eyes. It has a variety of uses. If used for a long time, then it can cause corneal anesthesia. Another reason for corneal anesthesia is what? A trauma, surgical trauma, right? If, for example, we are performing a surgery, for example, a cataract surgery, and for some reason, for incorrect usage, for improper techniques, whatever, the surgeon damages the cornea, then it might cause what? Corneal anesthesia. So if I take all the first letters, what do I get? H, D, L acts, right? HDL acts. HDL, you know, LDL, HDL, VLDL, high density lipoprotein, all of that. So HDL acts. This is the mnemonic for causes of corneal anesthesia. Done. Now, since we were talking about the nerve supply of cornea, and since we did talk about the corneal blink reflex, so let's talk about the corneal blink reflex in a little bit more detail, right? Let's talk about the corneal blink reflex. So basically, what was the corneal blink reflex? Obviously, by now, all of you know this, that I take a cotton wisp, I suppose this is my eyes, my eyelashes, okay, right. I take a cotton wisp and I touch my eye, or rather the patient's eye, or rather not the eye itself, but rather the cornea. What happens is the patient will blink. Right? Okay. I hope I am able to really convey what's going on here, but rather this is what happens, like the patient blinks. Okay. So this is corneal blink reflex. So see how the name itself has a reflex in its name. The name has a reflex in it, right? So any reflex means there will be what? An afferent pathway and an efferent pathway, right? Afferent pathway means what? The nerve impulse, the stimulus, is being carried over from the cornea by some nerve up to the higher center, which in this case is the brain. And then from the brain, the efferent pathway is another nerve carries the sensation, the motor nerve sensation from the brain towards the effector muscle. That is the efferent pathway. Basic biological knowledge, nothing to elaborate here. So what is the apparent pathway? Or rather the afferent pathway, not the apparent pathway, the afferent pathway. Afferent pathway is the sensory pathway and efferent pathway is the motor pathway. So obviously both of these nerves will be cranial nerves. That is one very, very important hint that I can give you. Another hint that I have already given you is the fact that I have already talked about the corneal nerve supply. Remember we talked about the cornea's nerve supply. What was that? Corneal sensations being carried over. What nerve was that? TON, ton. T for trigeminal nerve. So the afferent pathway will be trigeminal. Trigeminal means the fifth cranial nerve. What about the motor nerve? The motor nerve is the seventh nerve. Seventh nerve is the facial nerve. Now, we know that the sensations are being carried over from the cornea. But where are the motor impulses going to? The motor impulses, what is the motor function being carried over? The patient blinks. This is the function. This is the motor function that is being carried over. So, blinks means what? Blinks means something to do with the eyelid. So, eyelid, we'll talk about eyelid in another anatomy video in great detail. There we will see that the eyelid has different muscles. And basically for blinking, the basic muscle which is used is a muscle known as orbicularis oculi. Orbicularis oculi. Okay. This is the muscle that is the effector muscle. In this case, the effector target organ, target muscle, target tissue. Okay. The seventh cranial nerve actually brings the sensations to this muscle. Oculi means oculus. Oculus means eye. Actually, oculus means mirror. From mirror, since the eye acts as a mirror, so we say eye is like an oculus. So orbicularis oculi means the muscle in the eye. Why I'm mentioning this is because there is another muscle known as, and we'll talk about this later, orbicularis oris. This is not related to the eye, but rather to the mouth, the lip, our lips. Okay. So basically, do not get confused between these two muscles. How you remember? Oculus means eye or mirror, whatever you want to remember. So orbicularis oculus means something related to the eye, or rather in this case, the eyelid. Done. Now, what is the clinical correlation? Why am I, all of this that I'm talking about, reflexes and nerves and all of this, these are theoretical things. What good will this do, knowing this rather, do in my clinical practice? Well, the clinical correlation to this is a very, very special disease called Bell's palsy. We'll talk about Bell's palsy in a great lot detail. I think in ENT we'll talk about this in a great lot detail. In medicine also we'll talk about it in a great lot detail. But Bell's palsy basically is spasm, or rather palsy, in the seventh cranial nerve. See, the seventh cranial nerve is what in this case? This is the efferent supply. So if the cranial nerve, the seventh cranial nerve is affected in Bell's palsy, then orbicularis oculi will be what? There will be a palsy of the orbicularis oculi, right? So what this means is the patient is unable to blink. Unable to blink. This is called lag ophthalmos. Lag ophthalmos. Very, very interesting. So if you have ever seen a Bell's palsy patient, which I have seen multiple cases, if you ask them to close their eyes, you will see that see what happens is when we close our eyes, our eye, the eyeball, it moves upwards and the upper eyelid comes downwards. This is basically what happens. Okay. If you ask a patient with Bell's palsy to close their eyes, the affected part will not close. That eyelid will not close, or will close incompletely, but the eyeball itself will move upwards. So basically what you will see is, if this is just an extra edge information, we'll talk about this later. The eye is still open, right? This side it is closed because this is the unaffected side and this side is the affected side. This side is closed, but on this side it is open and this entire part is white. Why is this entire part white? Because the iris or the cornea or the eyeball has moved upwards, as happens in normal blinking or in normal closing of the eye. The eyeball moves upwards, but the eyeball has moved upwards, but the eyelid hasn't come down. That is why this entire part is the sclera. Again, you ask the patient to, try to open their eyes, and again it will become normal. Okay, so basically I don't know if I was able to really convey to you how a patient of Bell's palsy will present as. Obviously there are a lot more things to know about Bell's palsy, but this is a very, very important clinical correlation related to the corneal blink reflex and the 7th cranial nerve. That is why we have talked about it here. Now, very, very, very important part of our journey begins from here, which is layers of the cornea. See, cornea is a transparent membrane-like structure. Okay. Obviously, if we study anything in detail, it will become more complicated. Just like that, since now we have to talk about cornea in detail, it will become a little bit more complicated, but nothing to worry about. It has been found out that cornea is made up of 6 layers, or rather there are 6 parts to cornea, as is evidenced by this picture over here. So basically what we are seeing over here is, this is the superficial part and we are going all the way up to the deep part. Done. What are these layers? Remember, the superficial covering of almost any tissue in our body is, let me use this, epithelium. Over here, epithelium. Done. So epithelium is the first layer. Second layer is this layer called the Bowman's layer. Okay. Third layer is this layer called stroma. Okay. Fourth layer is this layer called the Duas layer. Okay. Fifth layer is this layer called the desmat membrane. And sixth layer is something called the endothelium. Okay, so these are the 6 layers. So let me just quickly jot them down for you. Anything, any superficial covering almost always in our body is the epithelium. Epithelium is always going to have what? A basement membrane. So just like that, this epithelium also has a basement membrane known as the Bowman's layer. Then most of the cornea is made up of the corneal stroma. Then there is a very tough layer of the cornea, or rather the toughest layer of the cornea, known as the Duas membrane or the Duas layer. Then another membrane-like structure known as the desmat membrane. And then finally, the outermost is epithelium, innermost will be endothelium. Endothelium. Now let's talk about these things in a little bit more detail. Okay, this is just the, I'm just laying down the foundation here, that is all. Okay, now see, let's talk about the first layer, which was what? Epithelium. So epithelium, obviously epithelium is of different kinds. We already know this from our basic biological knowledge. What kind of an epithelium does the cornea have? Well, let's describe it. It is non-keratinized, but it is stratified squamous epithelium. Okay. So it is non-keratinized stratified squamous epithelium. We know there are different varieties of epithelium. Obviously there is squamous epithelium, there is cuboidal epithelium, there is columnar epithelium, there is ciliated epithelium, there is stratified epithelium, there is non-stratified epithelium, there is keratinized epithelium, there is non-keratinized epithelium. This over here is a perfect example of non-keratinized stratified squamous epithelium. What does stratified means? Stratified mean laid down in strata. Strata means layers, which means that this epithelium is laid down in layers. There are different layers to this epithelium. If this was a single layer, we wouldn't have called it stratified. It would have been non-stratified. This is in layers, so it is known as stratified. Now, how many layers of epithelium are present? There are basically 3 layers. What are they? The superficial layer, the middle layer, and the basal layer. If we talk about these 3 layers in a little bit more detail, we will see that the superficial layer is the squamous layer. So, basically, this over here, okay, this is the superficial layer, this is the squamous layer, okay. The middle layer, this is an interesting layer. This is made up of multiple bat-shaped cells. So the middle layer, if I take up another, see, it is like this, bat-shaped cells, okay. Then the basal most cells, they are what we call to be columnar, okay. So even though we are calling this to be a stratified squamous epithelium, but that name is solely based out of the superficial most layer of the epithelium, which is squamous. But if we see the deeper layers of the epithelium, we will find out that this is the basal most columnar cells, this is the epithelial cells, or rather, obviously all of these are epithelial cells. This is the superficial most. Let me just erase this, just give me a second. This is the superficial squamous cells, and these middle ones, they are the bat-shaped intermediate cells, okay. What is very interesting about these cells is that the columnar cells, they have the ability to mitotically divide, which means that they are mitotically active. They can undergo mitosis, and that is what basically happens in a stratified epithelium. The basal cells undergo mitosis, and this is what happens in our skin as well, which is, by the way, our skin is an example of stratified keratinized stratified epithelium. So basically our skin epithelium also has different layers to it, and what happens is, from the deeper layers, the cells which are mitotically active, they divide, they keep dividing, and they keep pushing upwards. They become the bat-shaped middle layered cells, and finally become flattened to become the squamous superficial cells. So basically what all of this concludes towards is the fact that epithelium of the cornea can regenerate. Very, very, very important fact I have mentioned to you. What this means is, if the epithelium of the cornea, for some reason, perhaps a trauma, perhaps some disease, but only the epithelium of the cornea is abraded, has undergone abrasion, has undergone a break, only the epithelium is concerned, no problem. Epithelium can in fact regenerate in the cornea. So that is what is going on. Okay, done. Let's move on to the next layer. So now let's talk about the second layer. So we are done with, if I can just go back to this picture over here, we are done with the first layer, which is epithelium. Okay, you can see over here the epithelium, this, okay, I don't know why it's basically erasing, but that's basically it. So we are done with that epithelium layer. Now let's move on to the second layer, which was Bowman's layer. When I was talking about these layers, I said that epithelial cells will have a basement membrane. At the end, they are obviously, these are cells, right? So they'll have to stand on something. Let me just go back to this picture over here. See these columnar cells, if I like draw it a little bit better. Okay. So these over here, okay, I'm messing up big time. Anyways, so these over here, they're standing on something, right? This pink colored structure that I'm drawing, obviously this is what the cells are resting above. So this is the basement membrane. Basement membrane is basically, if we have studied a bit of histology, we already know basement membrane is the resting membrane over which the different cells rest upon. They stand upon these. Okay. But this is where a twist will come into play. Basically, I'm saying that the Bowman's membrane or the Bowman's layer, this is basically a basement membrane. Basically, it is a basement membrane, but it is not a basement membrane. So if you have to remember the Bowman's layer, you remember it like this, that epithelial cells obviously have to stand over something. The epithelium has to stand over something. That has to be the basement membrane. So basement membrane, basement, Bowman. Just like that, you can remember. Okay, you can correlate and remember. But then you also have to remember that basement, or rather the Bowman's layer, is not a true basement membrane. Very, very important. Why? Because it has been found out that any basement membrane, for it to be a true basement membrane, needs to be stained positive with something called PAS. What is PAS? Periodic acid skiff. Periodic acid skiff reagent. Any basement membrane, all the true basement membranes in our body, they stain positive with PAS, periodic acid skiff reagent. But this Bowman's layer is PAS negative. Okay. Now, just like a true basement membrane, it is acellular. So unlike a true basement membrane, it is PAS negative. But like a true basement membrane, it is acellular. What does this mean? This means that it is not mitotically active. This means the Bowman's layer cannot regenerate. Now do you understand why that knowledge was so important? If the epithelium gets abraded, degraded, torn down, broken down, only the epithelium is concerned, no problem, epithelial can regenerate. But if the Bowman's layer is concerned, then it cannot regenerate. Anything which cannot regenerate, when it will heal by a scar formation. There will be fibrous tissue formed. So it will heal by a scar. And if there is a scar formation on the cornea, because remember we are talking about the cornea here, these are all layers of the cornea. Cornea should be a transparent structure. But if there is a scar formation, can the cornea remain transparent anymore? Obviously not. So a scar would basically mean that there will be development of something called a corneal opacity. And this will hamper with our vision. Now, corneal opacity is a completely separate topic on its own. I'm not going to deal with it here. Maybe I'll make a short video on corneal opacities later. But basically, corneal opacities are of different kinds. Basically, it is based on how much of the vision is being lost because of that opacity. We don't have to go into the details right now. Just know this: Bowman's layer, not a true basement membrane, PAS negative, and it is acellular. So, it is not mitotically active. It cannot regenerate. Done? Done. Now, let's move on to the next layer. The next layer is the most important layer, or rather the most abundant layer in the cornea, the corneal stroma. Stroma means the uh, withholding body. Many structures in our body have a stroma. Many tissues have stroma, right? So stroma is basically the groundwork that holds all the layers together. If I go back to this picture over here, you can see that the stroma is the biggest, the thickest, the deepest layer. Okay, basically stroma is 90% of the total corneal thickness. Okay, so let's go back to our slide over here. Stroma is basically nothing but 90% of the corneal thickness contributor. Okay, now what is the stroma made up of? Well, the stroma is made up of something very, very important, type 1 collagen. It is not just made out of type 1 collagen, but type 1 collagen is the most common type of collagen fibers found in the stroma. What about the most common glycosaminoglycan? The most common glycosaminoglycans found in the stroma are keratin sulfate. So you can see that the stroma is basically made up of these glycosaminoglycans, these collagen fibers, and basically another very important thing about the collagen fibers in the stroma is the fact that these collagen fibers are laid very evenly. They are laid very parallel to each other. This will come in very handy when we'll talk about the factors which lead to corneal transparency. Basically what I'm trying to say is, see, the collagen fibers which make up the stroma of the cornea, they are arranged in such a way that they add to the corneal transparency. Okay, we'll talk about this in a bit detail a little later. Okay, just for now, remember that they are laid out in a fashion in which they add to the corneal transparency. Okay, okay. Now let's move on to the next layer, which is the Dua's layer. Let's use green. Dua's layer. What is Dua? Dua Lipa? Kind of. It is kind of Dua Lipa because Dua is actually the name of the person who discovered this layer. It is named after Dr. Harvinder Dua. Okay, so he is the one who first discovered this layer, and what he found out was, even when the cornea was undergoing some form of a trauma, or when the cornea was about to undergo some form of a trauma, or when there has been some form of superficial trauma, some layer within the cornea was resistant enough to not be damaged that much by that trauma. That is basically what led to the foundation for the discovery of a very tough, or rather the toughest layer of the cornea, which is the Dua's layer. So basically this is the strongest corneal layer. Okay, so if it is the strongest corneal layer, what is its thickness? Well, its thickness is a range. It ranges from 7 to 14 microns. Okay, Dua's layer, named after Dr. Harvinder Dua. Done. Dua's layer has another name, and that name is based on the next layer. The next layer is desmat's membrane. So the Dua's layer, which is just in front of the desmat membrane, is also known as the pre-desmat membrane. Pre means before. Okay, self-explanatory. This allows us to move on to our next layer, which is the desmat membrane. Desmat membrane is again another very important and interesting layer. So this is the fifth layer, the desmat's membrane. Desmat's membrane will come up in our discussion multiple times throughout the entire ophthalmology video series. Why? Because desmat's membrane has many functions, and desmat's membrane is very prone to getting damaged. We'll talk about desmat's membrane in different pathologies as well. So basically this is a very important layer of the cornea. Okay, the first fact that we need to know about the desmat's membrane is that the layer just under the desmat's membrane is the endothelium. We have already seen to that. Endothelium is what secretes this desmat membrane. So where is the desmat membrane coming from? Where is the desmat membrane formed from? Desmat membrane is secreted rather continuously by endothelium. Okay, which means again any fact that we are laying down has some form of a correlation to clinics. This means it can regenerate. Very, very important. So as of now we have talked about the epithelium, it can regenerate. We have talked about this Bowman's layer, it cannot regenerate because it is acellular. And now we are talking about the desmat membrane, which is secreted continuously by the endothelium, and hence it can regenerate. So it has been found out that the desmat membrane thickness actually it varies throughout life. Thickness will vary throughout one's life. So basically in childhood desmat membrane is thinner. As we age, it gets thicker because endothelium is continuously secreting the desmat membrane, and with this the thickness keeps on varying. Okay, now another very, very interesting thing about the desmat membrane is that, see, if I talk about how these layers are arranged, so remember this is the cornea, right? This was the cornea, this over here is the sclera, and this is the limbus. This cornea is what we are actually reading in a lot more detail here, studying in a lot more detail here. So I am what? Dividing the cornea into its different layers. Suppose this layer is the desmat membrane. This means that the desmat membrane, it ends peripherally at some point. These points where it ends, this forms a line, because think about it, the entire cornea is what? Three-dimensional, right? So if we are to look at the cornea or the entire desmat membrane overall, it will form a line. This peripheral termination of the desmat membrane will form a line. Can you imagine that? Good. That is called the Schwalbe's line. Schwalbe's line. Schwalbe or Schwalbe, whatever you want to call it, it's called the Schwalbe's line. So basically what I mean to say is peripheral termination of desmat's membrane is called Schwalbe's line. Done? Done. That completes the desmat's membrane. Now, the final layer of our eye, or rather the cornea, is the endothelium. Again, endothelium has a host of information to offer us. So, this is the final layer, and we already know something about this layer, which is endothelium continuously secretes the preceding layer, which is the desmat's membrane. Now, endothelium is first of all a single celled layer, not a single celled, but like basically that doesn't mean there is just one cell, basically means there is just one file of cells. Okay, not multiple layers, there is just one cell layer. Okay, first. Secondly, this is the metabolically active, not mitotically, I am saying metabolically active layer. Okay, metabolically active means it undergoes metabolism. How it undergoes metabolism? All those nutrients and all of that. Remember, cornea is a living tissue, so obviously it has to undergo metabolism. Which part of the cornea undergoes metabolism? Which part of the cornea is metabolically active? Endothelium. Done? Done. Now, very, very importantly, let's talk about the endothelial cells. Okay. Okay. The endothelial cells that I have drawn over here, if I zoom in over here, you can see what is just below the endothelium. So remember, this over here is the anterior part, this over here is the posterior part. So anteriorly we have the rest of the layers of the cornea. But what do we have posteriorly? Posteriorly, if you remember, let me just draw it. This over here is the iris. Over here in between the iris, this is something that I forgot to mention, I think, in my previous video. The space in between the iris, the hole-like structure that we see in the eye, is called the pupil. Okay. So basically what I mean to say is that where the endothelial layer is present, cornea ends. And what is present beyond the endothelium, posterior to the endothelium, we have already seen to this, it is the anterior chamber. So this over here is the what? Anterior chamber. And what is this? Posterior chamber. And then posterior to this we have the lens. Okay. Hopefully you are getting the entire orientation of the eye. We are basically dividing it into different sections and we are seeing the different orientations over here. Anterior chamber and posterior chamber together make up the anterior segment. We know all of this. Now, why I'm drawing all of this is because I have already talked about this. What does the anterior segment contain? It contains the aqueous. So, if I quickly draw the aqueous over here, suppose all of this is filled with what? Aqueous. Aqueous is what? I've already said this before in my previous video. Aqueous is a liquid. It is a watery liquid. So what will it try to do? It will try to flow. But it is bound posteriorly by the lens. Lens, and over here there will be the ciliary zonules and all of that. Right? Over here there will be the ciliary zonules. And then there will be the ciliary body and all of that. We're not going into the details of that. So anteriorly, posteriorly it is bound by the lens. So it cannot flow through that. But what about anteriorly? Anteriorly it is faced by the endothelium. So remember, endothelium, or rather the endothelial cells, what are they doing exactly? These endothelial cells are basically, they are stopping the aqueous from what? From leaking out. These endothelial cells, they are preventing the aqueous from going into the cornea. How they are doing that? They are doing that because of these special junctions in between them, which are called tight junctions. Tight junctions. Tight junctions also has another name, zona adherens. Zona adherens. So it is very, very important that the integrity of the endothelial layer of the cornea is maintained. Otherwise, what will happen? If these tight junctions were compromised in any way, what will happen is the aqueous will leak out. The aqueous will leak out. And then what will happen? They'll move into the cornea. So what is the problem if aqueous leaks into the cornea? I've already said that the cornea is transparent. It does not even have blood supply. Why did it not have blood supply? Because it had to maintain its transparency. Now, if a fluid moves into cornea, can it still become transparent? Can it still be transparent rather? Obviously not. It cannot maintain its transparency. It will become hazy. It will become edematous. That is why endothelial cells are very, very important in maintaining corneal transparency. However, this is not the only way that endothelial cells maintain corneal transparency. What is the other way? So the first way, and this is how we move on to another topic, which is corneal transparency. So let me just mention these 2 points over here. The first way that we have already talked about is tight junctions. Tight junctions is the way, what are we discussing right now? We are discussing the ways by which endothelium maintains corneal transparency. Okay, ways by which endothelium maintains corneal transparency. First is by tight junctions, by zona adherens. Second way is, remember, it is metabolically active, so it has what we say to be the sodium potassium ATPase pumps. The sodium potassium ATPase pumps within the endothelial cells, what they will do is they will help in maintaining the dehydrated state of the cornea. Very, very important. Basically, we cannot have any kind of fluid overload or fluid adequacy in the cornea. We cannot have too many fluids in the cornea. In fact, we cannot have much fluid, any fluid in the cornea. That is why even blood was sacrificed, right? So to keep cornea in this dehydrated state, we need the sodium potassium ATPase pumps, which are present within the endothelial layer. Done. So these are the two ways in which the corneal endothelial layer maintains transparency of the cornea. Now, what is the normal? See, endothelial cells are very, very important. So we need to know what is the normal cell count. What is the normal cell count of the endothelium? It is basically 2400 to 3000 cells per cubic millimeter. Or did I say cubic? I mean millimeter square. Per square millimeters, because this is a surface that we are talking about, right? So basically 2400 or 2400 to 3000 cells per square millimeters. This is basically the normal cell count of the endothelium. Okay. Now, if endothelial cells start decreasing for some reason, less than 2400, but are still greater than 500, then even then the endothelial cells remaining can make up for that. How can they make up for that? They can make up for that by something called polymegathism and polymorphism. What do these two things mean? Very simple. It is hidden in the name itself. Mega means size, poly means multiple, and mega means large. So polymegathism means that the remaining endothelial cells, they become large in size. Obviously, first they were this. Now, since the number of cells have decreased, they become large. This is polymegathism. What is polymorphism? Poly again means multiple, and morphology, morphos, means shape. So they change their shape to better suit their declining numbers. So polymegathism and polymorphism are the two ways by which the endothelial cells compensate for if their cell count becomes lesser than 2400 but is still greater than 500. However, and this is the question that obviously pops up in your mind after you hear about this, what about if it is less than 500? Then even polymegathism and polymorphism cannot do anything. This will lead to corneal decompensation, which means up until now there was compensation. Now there is decompensation. The cornea is no longer able to adapt. Okay. So what will happen? It will become hazy. Cornea will become hazy because the aqueous will now leak into the cornea. It will become edematous. And basically what will happen is there will be some form of a loss of vision. Vision will become very blurry. Now, how am I able to count these cells? These different cells. Obviously, counting cells, we are talking about cellular level, right? So what we need here is some form of a microscope. A microscope is used. What kind of a microscope is used for calculating the number of endothelial cells? A special kind of microscope called specular microscope. Just another fact to help you. Done? Done. So this ends our discussion on the endothelial layer of the cornea. Okay. Now, since we were talking about corneal transparency, there are some other factors by which corneal transparency is maintained. Let's quickly talk about those. So remember, we talked about corneal transparency being maintained by the endothelial cell layers by, first of all, endothelial layer. How did the endothelial layer do it? By tight junctions and by the sodium potassium ATPase pumps. But is there any other structure which helps in corneal transparency maintenance as well? Yes, there are different mechanisms for corneal transparency mechanism. I've already talked about one of those mechanisms, avascularity. Cornea is avascular, helps in maintaining corneal transparency. So another way that the corneal transparency is maintained is by the way the collagen fibers in the corneal stroma are arranged. How? See, first of all, the collagen fibers are uniform in their diameter, uniform diameter. Secondly, all the collagen fibers, and this is something that I already mentioned before, they are laid down in a very regular fashion. That is, they are equidistant from each other. They are equidistant from each other. And that distance is basically less than half the wavelength of light. So whatever light is coming, the wavelength of it, half of that wavelength, lesser than that is the distance between the collagen fibers. Okay? What happens because of this is there is no scattering of light. Why? This leads to destructive interference. Destructive interference. Okay, this is a point which is probably better suited for physicists to explain. I won't lie, I am not also very sure about this point, but this is something that has been given in multiple books of ophthalmology. So basically this leads to destructive interference, and what happens is scattering of light is no longer there. Okay, done. Then what else? See, the intraocular pressure. The aqueous, if there was more aqueous production, then the intraocular pressure will be more. Then if the intraocular pressure would have been more, it would have pushed on the endothelial cells and there might have been a leak. So the normal intraocular pressure also in some way leads to corneal transparency maintenance. Done. Another point that I hadn't mentioned when I was talking about the stroma, but is related to the stroma nevertheless, is the fact that stroma has special proteins called crystalline proteins. Crystalline proteins in the stroma. So stroma has the type 1 collagen fibers which are laid out in a specific manner. They also add to the corneal transparency. Also the crystalline proteins within the stroma also add to the corneal transparency. How? Crystalline proteins in the stroma, basically they actually reduce the backscattering of light. Okay. So these are all the different ways by which the corneal transparency is maintained. And with this, we end with the basic anatomy of the cornea. It is a very big topic, I know, but this is basically cornea. Okay. In another video, I think we'll talk about the sclera and its pathologies. I think this video has gone on for a little too longer than I had anticipated. So sclera, let's talk about sclera in another video. Okay. We will talk about the anatomy of the sclera. We'll talk about the scleral pathologies, how to differentiate in between them. And in that video itself, we'll talk about the limbus, because limbus does not have a lot to be discussed about. Cornea, on the other hand, had a lot to be discussed about. We have hopefully successfully discussed all of that. So thank you very much for sticking out up to the end. Hopefully this video helped you. Thank you very much, and I'll see you again very, very soon. Thank you.